Welcome to MediCrush, where we help you crush your medical examinations. Today's topic will be on pneumonia. So in terms of pneumonia, there are different types of pneumonia. The most common one will be community-acquired pneumonia, which simply means you have the pneumonia that you develop outside the hospital setting or within 48 hours of being admitted to the hospital. This is one of the reasons why we get a baseline chest radiograph to kind of see what someone's baseline x-ray looks like prior to admission, so that we know if they develop pneumonia within the first 48 hours, we know community-acquired pneumonia is going to be the cause. The second type of pneumonia is known as nosocomial or hospital-acquired pneumonia. And that's pretty much someone that develops pneumonia more than 48 hours after being admitted to the hospital. In this case, the bacteria you worry about a little bit different. Here you worry about bacteria such as Staph aureus, you worry about Pseudomonas and other gram-negative rods. So that sometimes will change your treatment based upon is it community-acquired or is it hospital-acquired. Now, similar to hospital-acquired pneumonia is what we call ventilator-associated pneumonia. And this is where someone has been intubated for more than 48 hours. Common bacteria are similar to hospital-acquired pneumonia, including Staph aureus and Pseudomonas bacteria. Now, nursing home pneumonia can also be seen in someone that was recently in a nursing home as well, and that can also sometimes change our management. Now, in terms of bacteria, you should kind of separate into two situations. You should know what your usual bacteria are, what I call the usual suspects, and know that your treatment usually covers those usual suspects. So let's dive into some of these usual suspects that you'll be tested on in most situations. Now, when you think of pneumonia, one of the ways to classify pneumonia is it classically typical pneumonia or atypical. Now, all pneumonias don't necessarily follow this pattern, but sometimes it's helpful to distinguish which bacteria that you should be worried about more so. So in typical pneumonia, we worry about bacteria such as strep pneumo, Haemophilus influenza, Staphylococcus aureus, and Klebsiella. They usually cause like a typical pneumonia. In terms of atypical organisms, those are bacteria such as Mycoplasma pneumonia, Chlamydia pneumonia, and Legionella pneumophila, as well as viruses and certain fungi can also cause an atypical pattern of pneumonia. Now, in terms of the first and most important usual suspect, the answer should be strep pneumo, because that is the most common cause of community-acquired pneumonia in both people who are HIV negative and HIV positive. It is the most common cause of a typical bacterial pneumonia in children of all ages. And one of the important gram stains you should know for exams is strep pneumo. They will describe it as gram-positive diplococci or gram-positive cocci in pairs. Very important for board's questions. Now, in terms of how they can present with like a typical pneumonia, so fevers, chills. They can throw in rigors in a question or even blood tinge or rusty colored sputum to denote hemoptysis with strep pneumo. Now, the second bacteria you should be familiar with is Haemophilus influenza, because that's the second most common cause of community-acquired pneumonia. So if you get a question and is looking for community-acquired pneumonia and strep pneumo is not there, there's a good chance H influenza could be a good answer because it's the second most common cause of community-acquired pneumonia. Who's at risk for developing this pneumonia? Anyone with any kind of underlying lung disease. So, for example, having COPD, bronchiectasis, cystic fibrosis. As a matter of fact, for people with bronchiectasis that is not due to cystic fibrosis, H influenza is one of the most common colonizers. If they have cystic fibrosis, you worry about Pseudomonas as a very common colonizer. So anyone that has any kind of underlying lung disease has an increased risk for developing H flu infections. Another very important one that's commonly asked is anyone with functional asplenia. So for example, people with sickle cell, usually around very young age, they develop functional asplenia where the spleen is not working. Why is that important? Because they had increased risk for what we call the encapsulated organisms. Normally your spleen can recognize these organisms and fight them off. But without a spleen, you are more susceptible to these organisms. That includes strep pneumo, that includes H influenza, that includes Neisseria infections, E. coli, Salmonella, and Klebsiella, and group B strep are some common encapsulated organisms. So underlying lung disease, functional asplenia, or any other kind of immunocompromised state can put you at increased risk for developing H influenza. Also very important is extremes of age. So young children under the age of 6 and older patients have an increased risk for developing H influenza as well. Now, the gram stain for this one may be described as gram-negative rods or coccibacilli, which are a combination of sphere-shaped and rod-shaped organisms. A third organism they may ask you about will be Klebsiella pneumoniae. Now, it is also known as a gram-negative rod. And again, some increased risk for this infection are people that have any kind of impaired host defenses. Some big ones, for example, is alcohol abuse. Alcoholics have a higher risk of developing Klebsiella pneumonia. Patients with diabetes and COPD can be some risk factors for this infection. Now, a very important thing about this infection, specifically Klebsiella, is that you can get necrosis and inflammation. That can result in what we call the current jelly sputum. They will describe this current jelly sputum as this thick mucoid sputum with blood or blood tinge is how I can describe this classic current jelly sputum because it simply looks like current jelly. Now, on imaging, you can sometimes see necrosis and cavitary lesions. So you can see an abscess formation or cavitation can be seen with this. Now, cavitation is not specific to Klebsiella. As you'll see in a few moments, you can see that with anaerobic infections or even Staph aureus can cause cavitations. But you want to think about this in your differential diagnosis if you see a cavitary lesions, especially with someone at risk factors for Klebsiella. Now, another bacteria you should be familiar with is going to be Staph aureus. Now, the key gram stain for this would be gram-positive cocci in clusters is how I would describe Staph aureus on an exam itself. Now, in terms of community-acquired, it's not a common cause of community-acquired pneumonia. However, if someone had a recent viral infection, like post-influenza, then Staph aureus could be a secondary bacterial infection. So community-acquired is usually in the setting of a recent viral infection. Another very important cause of acquiring Staph aureus is going to be hospital or nursing home acquired pneumonia. Remember I said earlier for those kind of pneumonias, you worry about both Pseudomonas and Staph aureus at increased risk. So look for community acquired in the setting of a recent viral infection, or look for someone that has hospital acquired pneumonia or ventilator associated pneumonia. You may be suspicious for Staph aureus in the differential. Now, similar to Klebsiella, you may either develop a cavitary lesion, or because it's a typical pneumonia, they may have a typical classic consolidation with or without an effusion. Now, some other things you may see, like I said before, is the cavitary lesion on the x-ray, but again, it's not specific. You can see that with anaerobes or with a Klebsiella. Now, another bacteria that we love to ask about in the usual suspects would be Pseudomonas aeruginosa. Now, who gets this one most commonly for community acquired? Look for someone that has some kind of underlying structural lung disease in which there's damage to the lungs, which allows for Pseudomonas to proliferate in that situation. A very, very important one on exams is cystic fibrosis. Many people that have cystic fibrosis or bronchiectasis due to cystic fibrosis are often colonized with Pseudomonas, so keep that in mind. People with COPD have an increased risk, again, because there's structural lung damage for those conditions or any kind of immunocompromised conditions. Now, the gram stain for Pseudomonas is gram-negative rods with a thick slime coat. Why is that so important? Is that thick slime coat makes it very hard for antibiotics to penetrate, which is why we have to use specific antibiotics to fight off Pseudomonas infection. Now, if it's hospital acquired or someone that has recently hospital stay, they can also be at increased risk for Pseudomonas. And again, ventilator-associated pneumonia, you worry about Staph aureus and Pseudomonas as increased risks. Now, those are your classic typical pneumonias. So now let's switch gears and talk about your atypical pneumonias. And these are the ones like mycoplasma, chlamydia, legionella, and viruses. Now, in terms of mycoplasma pneumonia, that's a very important cause you should definitely know for exams because it is the most common cause of what we call atypical or walking pneumonia. What does walking pneumonia mean? Simply means that I'm walking around living my best life. I may feel symptoms, but they're very mild and not so severe. Now, they may not only have pulmonary symptoms, sometimes they may have other systemic symptoms as well. But for the type of pneumonia, they generally feel relatively okay, so we call that the walking pneumonia. Now, a very important aspect about mycoplasma infection is that it lacks a cell wall. Why is that so important? Because it's hard to see on gram stain. But most important clinically is that any bacteria that inhibits cell wall synthesis cannot be used to treat mycoplasma pneumonia because it doesn't have a cell wall. So some big ones that we commonly use for pneumonias are penicillins and cephalosporins. However, these antibiotics cannot be used if you suspect mycoplasma because it does not have a cell wall. So very important for exams to remember that mycoplasma does not have a cell wall, so therefore you have to use atypical coverage for this infection. Now, who gets mycoplasma commonly on exams? generally speaking, it tends to be young and healthy people. So they don't have to be really sick to develop mycoplasma pneumonia. And remember, this is walking pneumonia. So these are like school age children, college students, for example, living in the dorms, military recruits if they're on a military barrack. These are some increased risk for developing this as well. Because it's seen in close spaces, there may be outbreaks, especially in the fall and winter when people aggregate together. Dormitories, barracks, prisons, some common places in which mycoplasma can spread very easily from person to person. Now, besides having classic pulmonary symptoms, mycoplasma pneumonia is often associated with atypical symptoms. Now, these could be just generalized symptoms that are not really that helpful. Malaise, myalgias, headaches, low-grade fever. That's not specific. You can see that with many conditions. Now, oftentimes they may have a cough. That cough could be prolonged, could be intractable, or maybe even be non-productive. In addition to that, they may also have a rash. It could be a generalized maculopapular rash that's non-specific. They can develop sore throats. They may have pharyngitis and erythema to the throat, a difficulty swallowing, for example. They may get red eyes, conjunctivitis, or some common non-pulmonary symptoms that are associated with mycoplasma pneumonia as well. Now, in terms of chest radiograph findings for mycoplasma pneumonia, the classic findings are what we call the reticular nodular pattern or interstitial pattern, which are not specific. You can see that with many type of atypical pneumonia. So it's not a specific pattern for mycoplasma, but it is yet a classic pattern for this condition because it is an atypical type of pneumonia as well. Now, fun fact about mycoplasma pneumonia is that it can cause cold agglutinin disease, a type of autoimmune hemolytic anemia. So, for example, about 50% of people that are infected with mycoplasma can develop cold agglutinin titers and a positive Coombs test specifically for complement, especially complement C3b and complement 3D. So if you see someone that has a positive cold agglutinin disease, you may be suspicious that mycoplasma could be a cause of this. Some common causes of cold agglutinin disease, I call them for IgM, is mycoplasma and mononucleosis like Epstein-Barr virus. Now, what about Legionella pneumonia, a very important atypical bacteria as well? Now, this bacteria is different because it is not spread from person to person. I can't cough on you and give you this condition. The key for this, look for some kind of contaminated water supply, very important in questions. This could be things such as shower heads, mist machines, cooling towers, AC units, for example, or in large facilities such as hospitals, apartment buildings, apartment complexes, hotels can spread it due to the contaminated water supply. Or very commonly could be outbreaks such as cruise ships or if an event happens where people are exposed to contaminated water. Now, the key for this in terms of risk factors for developing Legionella pneumonia is anyone that has any kind of underlying chronic disease. This could be lung disease, heart disease, kidney disease, that can put people at increased risk. Older people are also susceptible to this, smoking because it damages the cilia, and alcohol use or immunocompromised patients have a higher risk for developing Legionella pneumonia. Now, in terms of having pulmonary symptoms, because it's atypical, they may have outside of the pulmonary systems. So, for example, they may have GI symptoms, nausea, vomiting, diarrhea, abdominal aching. They can have CNS symptoms, and that could be any CNS symptom, CNS involvement. That could be altered status changes, delirium, headache, dizziness. These are non-specific as well. Now, in terms of labs for Legionella pneumonia specifically, they can often develop an SIDH, syndrome of inappropriate ADH, which can result in hyponatremia. So if you see pneumonia with a low serum sodium, you want to keep Legionella in your differential diagnosis. Some other very important labs that can be seen with Legionella is they can have increased LFTs, they can have increased AST and ALTs, non-specific, but yet that could be seen in the setting of someone at risk for Legionella who presents with a low serum sodium and increased transaminases. Now, again, in terms of radiographs, it looks just like all the other atypical organisms. So they can either have unilateral or bilateral patchy diffuse infiltrates or that classic reticular nodular pattern that's seen with many causes of an atypical pneumonia. Now, because this bacteria is very specific, it has a very specific treatment. Your three options to treat someone that has Legionella pneumonia is azithromycin, levofloxacin, or tetracyclines. I often say that if you get a question and you have no idea which antibiotic to use, and it sounds like a weird bacteria, a bacteria you've never heard of in school or you don't even remember that often, there's a good chance if you're not really sure and you put down either a macrolide or tetracyclines, that'll be a good answer. That's because they both cover gram positives, negatives, and what I call weird bacteria. So like unusual bacteria, often covered by either macrolides or tetracyclines. Now, another very weird bacteria, and if I say weird, you already know what kind of antibiotics can be treated for this condition, is what's known as psittacosis, ornithosis, or parrot fever. The reason why they call it that because someone has to be exposed to parrots or some kind of birds to develop this. The organism is known as Chlamydophila psittaci, very weird bacteria. And basically what happens is it is found in dried feces and secretions or contact with infected birds. And it really could be any bird. So if someone has a history of contact with birds, you want to think about this in your differential if they present with an atypical infections. So again, they present very similar to an atypical pneumonia, fevers, myalgias, malaise, very non-specific symptoms, but they can also develop severe headaches. That's a very classic thing for this condition. Also, fun fact is they can develop hepatosplenomegaly. The bacteria can infiltrate the spleen and the liver and cause hepatosplenomegaly in 10%. Not common, but classic for this condition. But most importantly is the history of bird exposure to make you think about this in your differential diagnosis. And again, because it's atypical, they may have the classic atypical pattern. So again, this reticular nodular ground glass opacity that could either be unilateral or bilateral. It could be multilobar, but again, it's very non-specific. So really the key is to focus on the history of bird exposure. Now, if you want to suspect this condition, you can order antibodies that occur usually around the second week of infection, or you can do microimmunofluorescent antibody testing for this condition. Now, because it's very weird, we can use tetracyclines to cover for this as a first-line therapy, or you can use macrolides as a second-line therapy. Now, not as effective for this could be things such as macrolides, or you could use fluoroquinolones for this infection as well. Now, in terms of anaerobic infections, you have to be worried about many kind of anaerobes that are found in the mouth. So that's things like Bacteroides, Peptostreptococcus, for example, some common bacteria that are associated with these infections. Now, to get this, you have to have some kind of impaired swallowing or cough reflex that allows you to aspirate the bacteria from the mouth to go into the lungs. So some common cause of this is someone that has poor dentition or really bad periodontal disease, like really bad gum disease, really bad tooth decay can develop an aspiration pneumonia. Or someone that has some kind of aspiration. So for example, Alzheimer's status changes, severe dementia, drug use, if they have like an alcohol binge and they're vomiting, they can have aspiration pneumonia. So look for someone that has these risk factors. Now, one of the key features of this condition on examination is that they may have this foul smelling or this putrid smelling odor because of this anaerobic infection that they have as well. So that's sometimes a tip off that you should be thinking about anaerobes in your differential if they have this foul smelling odor and associated with a risk factor for this condition. Now, they can have lobe involvement, especially involving the right lower lobe, just because of the gravity. It's the most dependent area. Or again, they can develop an abscess, so they may have a cavitation lesion. Again, a lung abscess is not specific or cavitation is not specific. We can see that with Staph aureus, we said earlier, or Klebsiella. But again, if someone has a risk factor for anaerobes, you want to think about this definitely in your differential. Now, we don't routinely cover for anaerobic infections just in general, but if you have a high suspicion of anaerobic infection or if they have a lung abscess, then you want to use something that's going to cover anaerobic coverage. So for outpatients, we commonly would use amoxicillin clavulanic acid because it has great gram-positive, negative, and anaerobic coverage. If you need IV coverage, we can use IV ampicillin sulbactam for the same exact reason. It's great for gram-positives, negative, and anaerobic coverage. If you don't use that, you can use moxifloxacin, for example, or you can add metronidazole or clindamycin for its anaerobic coverage for those infections. Now, in terms of the typical organism we said before, they can present with things such as fever, chills, cough, chest pain, pulmonary symptoms, dyspnea, rigors, especially with strep pneumo. If it's atypical organisms such as Mycoplasma, Legionella, or Chlamydia, they may present with other symptoms besides pulmonary symptoms. They may have sore throats. They can have, again, rashes. They can have dry cough or just sore throat or other symptoms that are not necessarily pulmonary related or may be in addition to the pulmonary symptoms as well. We said earlier that if you have Legionella pneumonia, they can also have CNS symptoms and GI symptoms as well. Now, very important for questions on exams is what would the physical examination show? So, for typical pneumonias, commonly they can have bronchial breath sounds over the area of consolidation. They can have dullness to percussion. They can have increased fremitus, increased tactile fremitus, wristed pectoriliquy. They can have bronchophony, egophony. These are all the classic descriptions of what you may find in examination over the consolidation in a typical pneumonia. Now, in terms of atypical pneumonias, the exam may be normal or they may have wheezing. The key is that they usually do not develop the signs of consolidation that we saw with typical pneumonias. Those are usually absent in these cases. In terms of Rales and Ronca, that's not helpful because you can see that with both typical and atypical organisms. So if I see normal examination, wheezing, or absence of consolidation, you can think of some of the atypical organisms. But again, it's not a hard and fast rule. Sometimes typical organisms can present atypically and vice versa. But it sometimes is helpful, especially for exam questions. Now, in terms of radiographs, you can either see a consolidation if you see a typical infection. They can have the classic reticulonodular pattern if it's an atypical infection, or you can see the cavitations with Staph aureus, with Klebsiella, or anaerobic infections. Now, in terms of how do you treat pneumonia, it all depends on two things. Where did they get the infection, and what do you plan on doing with them? So, for example, if you have someone that presents with community-acquired pneumonia, meaning they got it from outside the hospital or less than 48 hours of being admitted, and you decide to treat them as an outpatient, you have three main options. You can use amoxicillin, especially if you think it's a typical pneumonia, because it covers those usual suspects we spoke about earlier. If you suspect that it's atypical, however, we said, especially if it's mycoplasma, which does not have a cell wall, and remember that amoxicillin is a penicillin that works by cell wall inhibition, cell wall synthesis inhibition, then you cannot use it for an atypical coverage. So if you think that it may be atypical organisms or you have a high suspicion for that, then you probably would prefer to use either a macrolide or doxycycline because they cover gram-positives, negatives, and your atypical weird bacteria as well. So it all depends on if you think it's typical or atypical, which of these three that you would use. Well, what if they have comorbidities, but you still want to treat them as an outpatient? They have lung disease, for example. What are your options? We can start to extend the coverage by using amoxicillin clavulanic acid because that can extend the coverage. That has gram-positive, that has better gram-negative and beta-lactamase coverage as well, and also some anaerobic coverage to some extent as well. You can also use a respiratory fluoroquinolone as an alternative to the combination therapy if you want to just use one drug as opposed to using amoxicillin plus either macrolide or doxycycline for that atypical coverage organisms. Now, they may ask you about the curve 65. You definitely know the C. Again, confusion. They have a high urea. That could be a reason for indicating for admission. Again, if they have a low blood pressure, for example, that could be something you may be considering as well, or 65 or older. Usually 65 or older by itself is usually not the only criteria. You need to have some other criteria to make you think about if they're non-toxic. But if they're toxic, they really look sick, you should admit patients to the hospital. So if you decide to do community-acquired, treat it as an inpatient and is non-severe, you have two main options. Most commonly, we use a beta-lactam such as ceftriaxone plus a macrolide. Again, we add the macrolide for that atypical coverage such as mycoplasma pneumonia, etc. If you do not want to use double coverage, you can also use a respiratory fluoroquinolone as monotherapy. Specifically, levofloxacin, for example, moxifloxacin, and gemifloxacin are examples of respiratory fluoroquinolone. A very important fluoroquinolone that's not a respiratory fluoroquinolone would be ciprofloxacin, so you would not use that in this case here. Now, what about if you worry about MRSA? If you worry about MRSA and you want to treat them inpatient, you can use either IV vancomycin, very commonly used, or you can even use linezolid or daptomycin. My mnemonic is that MRSA likes to hang out on the boulevard. So Bactrim, B for Bactrim, is a very commonly drug used for MRSA. As a matter of fact, it's the most commonly prescribed oral drug for MRSA. You can use either linezolid, PO, or IV. You can use vancomycin, which is the first line IV drug in most cases for MRSA. Daptomycin can be used IV, and doxycycline can also be used to cover for MRSA. Not on this chart, but a notable mention could be clindamycin does also have some MRSA coverage as well. Now, in terms of if you were about Pseudomonas, you see the little guy over here, that's the Tasmanian devil. I like to say Taz, he goes around the hospital going, blah, you get Pseudomonas, blah, you get Pseudomonas. So if you see Taz in the name of the antibiotic, there's a good chance that it covers for Pseudomonas. So piperacillin tazobactam covers Pseudomonas. Ceftazidime covers Pseudomonas. Aztreonam covers for Pseudomonas as well. Now, what if they're a young child? So let's say 6 months to less than 5 years. What are your options? If you suspect a typical pneumonia, then we often use high-dose amoxicillin because it covers gram-positives, negatives, beta-lactamase, and even some anaerobic coverage. So it's great for typical organisms in young children. Again, if you suspect an atypical pneumonia such as mycoplasma, you want to avoid amoxicillin because it doesn't cover those atypical suspects. In that case, you can use a macrolide in young children when you suspect an atypical pneumonia as well. Now, if they're 5 years or older, you can use a macrolide such as azithromycin can be used, especially if it's atypical. But again, if it's typical, you can also still use amoxicillin safely in those patients, in these young children as well. Now, some other kids, you can use a kind of combination therapy with either macrolide plus amoxicillin, or again, that's kind of what we can use as an alternative. But again, for the most part, you prefer to use either a macrolide or amoxicillin, depending on if you think it's typical or atypical. So now that we've gone over the usual suspects and we talked about the treatments, now it's time for questions. So for this session, what I want you to do is I want you to pause the question. That way you can look at the whole question and figure out your answer, and I'll walk you through why the answer is the answer that it is. You ready? All right, let's do it. So in this question, I'm asking you, which of the following examination findings is most specific for a lobar consolidation? So in other words, a classic for typical pneumonia. Of the choices that are listed here, increased fremitus is a classic finding for typical lobar consolidations. Again, increased tactile fremitus, bronchophony, bronchial breath sounds, egophony. These are some classic findings that you will see over the consolidation as well. Now, absent breath sounds usually indicates a pneumothorax. Hyperresonance percussion usually indicates air in the pleural space. Rhonchi are not specific. You can see that with both typical and atypical. And bronchovesicular breath sounds are normal breath sounds. So let's try another one. So in this case, which of the following features are most suggestive of an atypical pneumonia? In this case here, for atypical pneumonia, you can expect things such as wheezing, for example. Wheezing is very commonly seen with atypical pneumonia because, again, it can affect the respiratory epithelium, but again, it's not specific. But of the choices that are listed here, that is the one that's more hallmark for an atypical presentation. All the other choices listed here, besides wheezing, are more commonly seen with typical infections. So in this case, this patient presents with productive cough, fever, and chills. They have classic findings of consolidation. So they have egophony, they have increased fremitus, they have right middle lobe consolidation. So in this case, they're giving you a classic typical pneumonia, which means in most exams, you go for your most common. A very important test-taking tip is that, generally speaking, go for the most likely diagnosis. If I don't want you to put that down, I would either remove that as a choice or I have to add it to the question to make it not the most likely. So in this case, it's a classic run-of-the-mill question, so I'm going to go for my most common. Remember that strep pneumo is the most common cause of community-acquired pneumonia, and remember that classic finding on gram stain will be gram-positive cocci in pairs, also known as gram-positive diplococci. So that would be the most likely cause of this patient's pneumonia by far, both in adults and children. So in this question, the patient has a lobar consolidation. They have a history of COPD, which means they have underlying lung disease, very important. And they have E to A changes, which means that there's evidence of a consolidation on examination as well as on imaging. However, the vital signs are not crazy, which means that we can treat this person as an outpatient. So in this case here, we're treating someone that has community-acquired pneumonia as an outpatient, but they have a comorbidity because they have COPD. In that case, we want to extend the coverage with amoxicillin clavulanic acid because that covers my gram-positives, my negatives, and my anaerobes. Plus, we're going to add azithromycin to cover for my atypical organisms, such as mycoplasma pneumonia, since it doesn't have a cell wall, and therefore cell wall synthesis inhibitors will not work against that. So in this case here, this will be the preferred treatment for someone that has community-acquired pneumonia treated as an outpatient with some kind of underlying comorbidity. So the key in this question is the person has like non-specific symptoms. However, they're a pet shop employee. They work with birds. It's very important. So that history is a very important part of this question. Again, seen only 10%, but still important is that if you see hepatosplenomegaly with bird exposure and these classic changes, you have to be worried about chlamydia psittaci, which is also known as parrot fever. Remember, it's very weird. You have to be exposed to certain birds, things like that, which means I want something that's going to cover that as well. So my option could be doxycycline because it covers gram positives, negatives, and weird stuff. I could use macrolides as an alternative to this as well. You could use fluoroquinolones like choice A, but again, it's less effective compared to tetracyclines and macrolides. So therefore, tetracyclines first line therapy, macrolides a second line therapy, making the best answer here, choice B. So in this question, this patient had COVID, they were intubated, and they were intubated for a few days. They were hospitalized and intubated, which means in this case here, I don't have to worry about hospital-acquired pneumonia, very specifically ventilator-associated pneumonia. Remember, for ventilator-associated pneumonia, there are different usual organisms, but there are two other ones you have to be worried about, and that's going to be Pseudomonas and Staph aureus. And only one of them is here, so therefore the answer best would be here. Pseudomonas is something to be worried about, could be a cause of this as well. Pseudomonas kind of lives in the tubing as well of intubation, so that could also be a reason why they can develop this as well. It forms a biofilm around the tubing and therefore can colonize the tubes as well. So in this case, you have a young, healthy patient, 19-year-old. Otherwise, no real problems. He has this dry cough, these non-specific symptoms. He has a sore throat. He has subjective fever. He was recently at a training base, which means he was exposed to other people. And is a classic atypical pattern of this particular nodular patchopacities, which makes me think of a high suspicion of mycoplasma pneumonia. Remember that for mycoplasma pneumonia, they can also, 50% can also develop cold agglutinin disease, which means they can have either a cold agglutinin titer or a positive Coombs test specifically for complement 3, complement C3b, and C3d, making the best answer here, choice C. Heinz bodies are more commonly seen in patients that have G6PD deficiency. An increased MCV could be seen in someone that has either B12 or folate. Hyperchromic microcytic cells will be seen in someone with iron deficiency anemia or thalassemias. And a positive osmotic fragility test is not specific. You can see that with things such as G6PD deficiency or spherocytosis. So in this case, this patient has a classic lobar consolidation, and the key for this is that they also have a history of sickle cell, which means they have functional asplenia. In this case here, you have to be worried about either H influenza being the most common cause in this case here. Now, it could also be strep pneumo because remember that's also encapsulated, but in this case here, remember the rule of thumb for exams. You go for the most common, or I can remove the most common. In that case, you go for the second most common, or I have to add into the question. So in this case, they remove strep pneumo as a choice. They added the sickle cell and asplenia, so you can think more so of H influenza, which is the second most common cause of community-acquired pneumonia, making that the best answer here. So in this question here, you have a 4-year-old kid comes in with a low-grade fever. He's non-toxic, which means he has a lobar consolidation. We said before, for young children, we prefer using amoxicillin. It is a preferred treatment for typical pneumonia, as this patient has a typical consolidation, making that the best answer here. So in this question, you have an older person that's disoriented. They have a high respiratory rate. They have a BUN that's 28. So in this case here, because of that reason, this person you want to admit to the hospital based upon curve 65. And we have two options, either fluoroquinolone by itself, or in this case here, ceftriaxone plus azithromycin to cover for your atypical organisms. So in this case here, this person has a cavitary lesion. They have poor dentition. They have this foul smelling odor to the sputum, which makes me have a high suspicion for anaerobic infection, and also because there's an air fluid level, you're worried now they probably have a lung abscess, which means you should cover gram-positives, negatives, and the anaerobes that are found in the mouth. So the choice that are listed here, ampicillin sulbactam IV would be the preferred treatment for IV. If you were doing outpatient management, you can use amoxicillin clavulanic acid for this patient. So you made it to the end. You crushed it. So again, if this video was helpful for you, I want you to like it. Put a comment down. Let me know what part was helpful for you so that I can also know how to make these videos better. And also share with your friends. Sharing is caring. Also very important, subscribe if you can. That way you get notifications when the new videos come out. So again, thank you for tuning in.